Good morning, everybody. I work here at Mount Sinai, New York, and we're going to talk about detection and decision and how to avoid unnecessary surgery. So, with the widespread use of low-dose CT screening and incidental imaging, pulmonary nodules are increasingly detected. Challenges is early detection saves lives, but most nodules are benign or clinically insignificant. Management of pulmonary nodules requires a careful balance between achieving curability for malignant lesions and avoiding unnecessary surgery for benign or indolent disease. So what do we have of guidelines to guide us through this massive, the science of who to operate on and who not operate? So we have Fleischner Society size-based threshold, NCCN, BTS, structured follow-up. And for all of that, his goal is to minimize benign resection without missing cancers. Historically, in 1960s, 65% of all resections were benign. And remember, it was done with big thoracotomies. In 80s, about 20 to 30%. Florizidol here at I-ELCAP showed 11% in a screening population, but basically it was 2% if the recommendations follow-up had been, followed. Other groups like Alametal from Brigham had 15%, and Balata et al. From the Manchester group in UK showed 4% of benign resections. So this is good. This is good because we can see the numbers of benign lesions is going down. What is the goal? We're going to get into that. So for assessing malignancy risk, we have risk models, Brock, Mayo, and Herder. Radiology for the size, growth pattern, morphology, and density. We also have PET-CT, which is sensitive, but false positives with infection, inflammation. Also, it really doesn't work with nodules less than 1 centimeter or 10 millimeter. We need to find out which population cohorts we're talking. Is it a screening cohorts? The malignancy prevalence is 3 to 4%. Incidental nodules on incidental nodule programs is about 5 to 10% malignant, or surgical referral cohorts, which is about 50% malignant. So that's the population mix explains differences in benign resections. For malignant nodules, timely surgical resection with minimal invasive surgery, wedge segmentectomy, lobectomy can achieve cure. But also we remember here that most of the benign resections is done with the wedge. Archer group from Brigham showed almost 84% of the benign resections, they were from the peripheral nodules. So peripheral nodules if you have a peripheral nodule on the CAT scan and we are unsure about it, is a higher risk that it ends up as surgical biopsy. Also knowing that delayed intervention risks disease progression beyond operability. So benign nodules, granulomas, infections, inflammatory lesions may be indistinguishable without tissue diagnosis. Unnecessary resections carry risk of reduced lung reserve, complications, mortality. As surgeons, we know even doing a wedge resection can have complication for the patient, and some patients die. So, and also psychological and financial burden for the patient. Also, overtreatment is especially relevant in subsolid and indolent lesions like AIS or MIS spectrum. Impact of nodule size on benign resection rates, very important. So usually we say lesions under 8 millimeter, majority benign, surveillance recommended. very few resections in this group. 8 to 20 millimeters, these are the mixed risk. Most benign resection occur in this range, and over 20 millimeter usually malignant. So we look at this. So basically, all the resection for the benign is from above 8 to 20 millimeters. Above 20 is basically they are malignant. Composition of the benign resected nodules. So 79, 80% of them, they are solid. About 16% is part solid, and only 5% as GGOs. What do we have of tools to decide what is the diagnostic tool to find out if this is malignant or benign? So CT-guided transthoracic biopsy has a high yield, but pneumothorax risk, about 15-20%. We also have, the pathology should be very also on board, because it sometimes is difficult, even with the cytology, to get the diagnosis. Few scanty cells, so it can end up as non-diagnostic. We deal with it on daily basis. Conventional bronchoscopy, safer but lower yield peripherally. Robotic bronchoscopy and cryobiopsy. I think that's a game changer. Navigates reliably to peripheral nodules. Cryoprobe retrieves larger intact specimens. If not, is as good as CT-guided biopsy, but you don't get a cytology, you get a pathology specimen, surgical specimen. Surgical pathology specimen. Has lower pneumothorax risk than CT-guided biopsy. There is bleeding risk, but the risk, the catheter is about 1.2 millimeter. So it's not, you can see sometimes it's bleed when you pull back the catheter, it's basically nothing. Future directions, radiomics, AI for better imaging-based risk prediction, liquid biopsy and blood-based biomarkers, personalized surveillance intervals. So most nodules, we should think this, most nodules are benign. Surveillance is key, and this is very important, adhere to the guidelines to avoid unnecessary resections. PET-CT is good to use, but when indicated. Robotic bronchoscopy with cryobiopsy or CT-guided biopsy prevents diagnostic surgery. So when you look around the literature, for surgical cohorts, as I showed, it's very high for the benign resection. We try to take it down to less than 10%. This is arbitrary. There is no guidelines for that. And for screening programs, it's 5%. To achieve that, it's very important to use every tool. One of them is multidisciplinary tumor board. These cases needs to be discussed, where oncologists, radiation oncologists, pulmonologists, radiologists, they are, and they can, make a precedence for what the next step. And not to forget patient preference. We deal that on a daily basis. We present it to patient that you have a nodule. We have tried a biopsy, CT-guided biopsy, didn't show anything, it's inconclusive, and bronchoscopy is also didn't get, it's suspicious, but we don't have the result, and patients say, well, take it out. And then we have to speak, is this a limited resection? Is it a wedge? Is it segmentectomy? Or is it lobe? Because for us surgeons, is when we talk about lobectomy, I don't think anybody wants to do a lobectomy on a benign resection. So target 10% for benign resections in surgical cohort, less than 10%. Again, these are our, we can talk about 6 to 7%, but this is when we can start from. And then for screening program, less than 5%, maybe 2-3%. And that's basically achievable with the tools we have right now.
I actually was going to ask you just one question for clarity. Surgeons have, guideline organizations or, that you have reviews. So if your hospital is getting 40% benign lobectomies, let's just say, does somebody come say, hey, does anybody look at that and say, hey, you're doing too many surgeries? I mean, is there some agency that says this?
Depends on which hospital you're working at. In a hospital like, we, on Sinai, we try to do it, we work with Dr. Flores. And I don't think anybody, or under his guidance, I don't think anybody wants to do a lobectomy on a non-diagnostic. It can happen very rarely, but nobody wants to do. Again, if this is a wedge, is a peripheral, maybe sometimes we make that decision, but we probably, if one or twice is non-diagnostic, maybe if you go for the third time, and then we discuss it.
Right, but is there an agency that oversees and overlooks? No?
Yeah, and that's a big problem. So 40% benign rate, you need some check on that. The hospital's not going to care. Those are cases, the hospital's happy with it. It's up to us as physicians to make sure that, me as a chief, when I see a lot of those coming out, then I need to talk to the attending about it and say, hey, we're doing, it affects your quality, but the hospital is not going to pick it up. The hospital welcomes more cases. So that's the reality of it. But I thought that was an excellent presentation. But the thing is, let's say in a surgical cohort, 10% that, or let's say in the screening cohort, 5%, that means 1 out of 20 patients you're screening are getting surgery for no reason. We got to do better than that. So, when a patient has something, their initial reaction, doc, get it out, get it out. But we can't have 1 out of 20 patients going to surgery when they didn't have to.
So I can answer. So there are some studies that show they have less than 1%, but they are single center studies. We don't have the real, it's just a good study to, show what is there, and where we can take it down to.
I think we have a luxury here at Mount Sinai. When we have a nodule and we're not sure whether to take it out or not, we go to Claudia and David and we say, should we take this out? Many times they'll say, no, you can watch it. So not every program has this kind of expertise, unfortunately.
But there's no published really guidelines though for this. There's no, here's the standard of care. It's interesting. I thought there might have been. Okay, next speaker. And we'll get.
Okay, one more question. David?
Yes.
Where? Oh,
Where?
Dr.
Hey,
Moganowski.
so excellent presentation. The bullet point that said MDT conversation. So I'm not a thoracic surgeon, but I'm often involved in these MDT conversations. What are your recommendations when 1 or 2 people in the MDT, like a pulmonologist or a radiologist, gets a little panicky and says, oh, if that was me, I'd want it out. But then there's other people in the MDT saying, you can watch it. Often what I sense that once one person gets a little panicky about a subsolid, the patient ends up in the operating room. What is your recommendation for managing that?
I think at the end, it comes to surgeon's comfort level and the interaction with the patient. As I brought it to the last point, patient's preference. So you bring the board decision or recommendation to the patient. That's what I do. Bring it to the patient. Say, some people were for it, some people were against it. So what do you want to do? My recommendation is, for example, not to do it. So no, I don't want to have the feeling of having cancer in my body. Well, then we have to. But again, if this is a limited resection, if this is a lobectomy, then I will say, you know what? If I will wait, if this is shorter surveillance.
We're going to explore a bunch of this and start to try to see how we can put some numbers or science in it. We're just going to start touching on this. Is a big topic.